My name is Dr. Brad Barth, and I am a pediatric gastroenterologist at UT Southwestern and an associate professor of pediatrics. I work at Children's Medical Center in Dallas, and I'm here with Dr. David Trundle, who is an assistant professor of pediatrics at UT Southwestern, also at Children's Medical Center in Dallas. And we are here to discuss and answer some questions about his recently published article titled Factors Associated with Post-ERCP Pancreatitis and the Effect of Pancreatic Duct Stenting in a Pediatric Population. So, Dr. Trundle, first off, can you tell us a bit about why this topic should be important to the GI endoscopy readership?
Yeah, sure. So first, I want to just thank the Journal of Gastrointestinal Endoscopy for providing us this very unique forum to share our work, and you, Brad, also for getting this manuscript together with me so quickly. I think there's several reasons why this topic is of general importance to the readership of GIE. First of all, we know that over the past decade, the utilization of ERCP in the pediatric population is increasing. And there's several reasons for that, one of which is there's been a rise in the obesity epidemic amongst children, and then thus the rates of choledochal lithiasis have gone up. And as you know, and has been published recently and in other publications, is that this is the most common indication for ERCP amongst children. Also with that, there's been an increase in the number of pediatric gastroenterologists who are both competent and comfortable performing ERCP in children, thus increasing access to care for these patients. And so we're seeing more and more of these procedures being performed in children. With that, I think we have to make sure that we're all performing procedures for appropriate indications and also doing what we can to identify those patients who are at highest risk for developing adverse events, such as post-ERCP pancreatitis, and also intervening to mitigate these risks when appropriate. In looking to the literature, this appears to be where the hole is, and this is what we tried to address in this study. While there's several very large design studies in adults identifying risk factors for post-ERCP pancreatitis and then subsequently evaluating interventions to mitigate those risks, almost without exception, all these studies specifically exclude children and pediatric patients from the study's design. And so this makes a dilemma for the endoscopist performing this procedure in children in that they have to adapt what we have shown in adult patients to the pediatric patient, which, as our study will show, I think may not always be appropriate.
Can you discuss your study design and summarize your results?
Sure. So very quickly, this was a retrospective review of 432 ERCPs performed over a 9-year period ending in 2013. These ERCPs were performed here at UT Southwestern in Children's Health. We looked first, we did a univariate and then subsequently a multivariate analysis looking at factors associated with post-ERCP pancreatitis. The factors we decided to analyze were those that had previously been identified in adult studies, and we also looked at some factors we thought were unique to pediatric patients, including their age and size as well. What we found were that injecting the pancreatic duct with contrast was positively associated with the development of PEP, as was performing a pancreatic sphincterotomy. Both of those were independently associated with the development of PEP with an odds ratio of 30.8 and 3.8 respectively. We also found, probably not surprising to most of the readership, that having a history of chronic pancreatitis was protective from developing PEP. What we wanted to do next was to evaluate the effect of pancreatic duct stenting at preventing pancreatitis in high-risk pediatric patients. And so what we did was we defined a high-risk pediatric patient as being either in those that had one of the risk factors that we identified, either having their pancreatic duct injected with contrast or who underwent a pancreatic sphincterotomy. In those patients, we looked at and compared rates of pancreatitis in those who had no attempt at stent placement to those who had a pancreatic stent placed. And what we found was that there was actually a positive association with the development of pancreatitis in those patients who had a pancreatic stent placed.
So I bet you that's a bit controversial. Can you talk a bit about something I found interesting as well? When patients had pancreatic stents placed for therapeutic indications, their risk of pancreatitis was not increased.
Right. I think it's important to point out. One of the first things we wanted to do was to make sure that this observed increased rates of pancreatitis in patients who underwent stenting wasn't due to the fact that some patients do actually undergo pancreatic stenting for therapeutic purposes, for example, if they have pancreatic strictures. duct strictures. And so we next excluded those patients from our analysis and looked just at those patients who underwent stenting specifically for the purpose of preventing post-ERCP pancreatitis, and compared those patients to the patients who were at high risk but did not have an attempt at stent placement at all, and found that the increased association with post-ERCP with pancreatitis after the procedure remained. So our study would suggest that the development or placing a pancreatic stent specifically for the purpose of preventing pancreatitis in high-risk pediatric patients is actually associated with an increased rate of pancreatitis in those patients. And then to your point that the patients who had therapeutic stents placed, their rates of pancreatitis were not increased compared to those who had no attempt at stent placement. That is likely due to the fact that all those patients already had a history of chronic pancreatitis, which, as our paper shows and others have shown previously, is actually a protective factor.
All right. So what's next? Where do we go from here, and what do you see as challenges moving forward with pediatric ERCP and post-ERCP pancreatitis?
Well, studying ERCP in the pediatric population or any advanced endoscopic maneuver in pediatrics is inherently difficult because of the relative volume that we do compared to our adult colleagues is going to be low. Just to highlight that fact, we recently surveyed 30 endoscopy directors at the largest pediatric centers around the country and found that very few, if any, of those centers are performing more than 100 ERCPs annually. So that's going to make it very difficult to obtain any meaningful information in a timely fashion, and so it's likely that to study this in the future we will need a multi-center approach. This is something that we've been piloting over the last year, as you know, with several of the large centers around the country where we're prospectively gathering ERCP information into a multi-center database designed specifically to evaluate technical outcomes after ERCP. So we're hopeful that this approach will provide us more definitive information in this regard.
That's great. So before we conclude, can you give us a few take-home points?
Sure. I think that our study again shows that ERCP can be safely performed in the pediatric population, and rates of pancreatitis are in the 10 to 11% range. That injecting the pancreatic duct with contrast or performing a pancreatic sphincterotomy are associated with increased rates of pancreatitis, and having a history of chronic pancreatitis appears to be protective. And our study would at least suggest that placing a pancreatic stent specifically for the purpose of preventing pancreatitis is associated with increased rates of pancreatitis in high-risk patients. And while more work is needed in this arena, and I understand that many providers will continue to try to place pancreatic stents to prevent pancreatitis in pediatric patients, they should do so with caution and careful monitoring.
Thank you. Congratulations on your publication.
All right. Thank you.